Emergency Management of Intussusception, a short tutorial for Discover Pediatric Surgery by Nirav Patel, Ellen Mapunda and Hansraj Mangre. Intussusception is the most common cause of bowel obstruction in infants and young children, and usually follows a viral respiratory or gastrointestinal tract infection. Intussusception is slightly more common in boys, usually occurs between the ages of 3 months and 3 years, and is most often noted in thriving children. In intussusception, some part of the intestine falls or telescopes into another. In most cases, intussusception is ileocolic, with the ileum telescoping into the colon. This process results in pain, abdominal distension, and ultimately intestinal obstruction. Children with intussusception present with a history of acute onset, intermittent, and severe abdominal pain that may be associated with sweating and irritability. Parents classically describe their children as being extremely irritable, drawing their legs to their chests with sweating and vomiting. These episodes of intense illness are followed by periods of lethargy. As the disease progresses, patients may experience abdominal distension, bilious vomiting, and per-rectal bleeding in the form of red currant jelly stools. Importantly, bilious vomiting and per-rectal bleeding are late signs suggestive of established obstruction and intestinal ischemia. Clinically, children with intussusception may appear ill and have abdominal distension. In severe cases, the patient may also appear dehydrated and in respiratory distress. Abdominal examination can reveal distension, an emptiness in the right lower quadrant, and the mass that may be palpable in any abdominal quadrant. PR examination can reveal a mass, blood on the glove, and in extreme cases, the intussusceptum may even prolapse out of the rectum. Intussusception is often misdiagnosed with gastroenteritis, dysentery, rectal prolapse, and even colic. Always maintain a high index of suspicion for the diagnosis, as patients that present late often require intense surgical management. When diagnosed early, intussusception can often be managed non-operatively, resulting in shorter hospital stay and lower rates of morbidity and mortality. Abdominal X-ray is a useful first investigation and may demonstrate a lack of air in the right lower quadrant, evidence of intestinal obstruction as demonstrated by dilated tubular loops of small bowel, and a soft tissue density or mass. Ultrasound confirms the diagnosis. If X-ray or ultrasound are requested, they should ideally be performed at the bedside. If this is not possible, the patient should be accompanied by medical staff until all investigations are complete. Remember, it is not necessary to confirm the diagnosis in order to refer the patient to a specialist center. In those children with suspected intussusception, remember to keep the child no pause, keep the child warm, place a nasogastric tube and leave it on free drainage, establish IV access and administer appropriate resuscitation and maintenance fluids, give oxygen and analgesia, and counsel the parents on the possible diagnosis, the measures being taken to manage the problem, and the need for referral to a specialist center and the possible need for surgery. Always maintain a high index of suspicion for intussusception. Remember to ask parents about a history of preceding illness and whether their child has been experiencing vomiting, pain, and irritability alternating with periods of lethargy. Clinically, be aware of an irritable child with an emptiness in the right lower quadrant and a possible palpable mass. Never leave patients with suspected intussusception unaccompanied. Start early and appropriate resuscitation and refer early to avoid unnecessary and potentially life-threatening complications. Thanks for listening, and please visit the Surgeons for Little Lives website or the Discover Pediatric Surgery YouTube channel to download and share this and similar tutorials for free.